Hi, my name's Jonelle Potter, and I am here in Miami at the University of Miami Miller School of Medicine with my colleague and my friend, Dr. Deborah Jones-Weiss.
Yeah, and I'm with the Department of Psychiatry and Behavioral Sciences at University of Miami at the medical school. And I believe that we're going to be talking about, well, a variety of different topics, but we're going to talk a little bit, maybe we'll start by talking about some of the work that we've done here in terms of understanding some of the issues that men and women face that are related to desires to have children. So one thing, actually, this was Jonelle's inspiration. She was the person that really got me very interested in the whole topic. And the more looking that we did, the more we uncovered. And I was kind of thinking about it the other day as realizing that we peeled away the layers. I actually thought of it as we pulled the bed covers away off of the bed to find out what was going on underneath the covers. And what was going on underneath the covers was really interesting. We got very excited about the idea that a lot of women who were positive and their partners, male partners who were positive, male partners who were negative, but in general we were looking at women wanted to have children, and Jonelle said to me that they really didn't know much about the entire issue, and so we talked about it a lot, and we decided to put together a few studies, and we ran a study looking at women and partners, and the women were all positive and the men were positive or negative, and we asked them what their desires were, whether they wanted to have children, and about 80% of the women that we talked to did. Some women were older, and we were surprised, but it didn't matter. And we found that women wanted to have kids, a lot of their partners wanted to have kids, and that to a large extent they were concerned about talking to their providers about it, talking to their doctors. They felt, all of them, they said they had good relationships with their doctors, but they felt just a little discomfort, inhibition, whatever it was. And so we thought, what's that about? We also did some interesting interviews with women and men, and we looked at how women make decisions. And we found that older women were more likely to make a decision about having children based on what their doctor told them. And younger women were more likely to make that decision based on what their boyfriend wanted, or their partner, whatever you might want to think of that term as. And then we decided that the next thing to do was to talk to providers themselves and find out, what are they doing? Are they talking to patients? We talked to doctors who were OBGYN doctors. We talked to doctors who were doing infectious disease work. And we found, as you and I have been talking, that each thought the other one was addressing the topic. That there wasn't really time. As one doctor said to me, they asked the question, not do you want to have children, but how are you preventing pregnancy? Check. And they would check the answer off. Yes, the person is preventing pregnancy, this is what they're doing. And we had a lot of interesting focus groups and discussions about how that procedure should go. And we discovered along the way that there was a really good protocol on preconception counseling, and it was not being implemented. That was kind of the sad part of that story. Then we met with patients again in focus groups, and we talked with them about, what do you want? And it was really interesting because we discovered that women who were thinking about getting pregnant, that the way they thought about it wasn't the way that the doctors talked about it. That the doctor might say, are you planning on having children? And they would say, yes, I am. And they'd say, what are you doing to prevent pregnancy? And they'd say what they were doing to prevent pregnancy. But the women would say, I'm not planning on getting pregnant right now. And that it would follow, but they wouldn't say it, but maybe tomorrow. So that the whole concept of time and planning was different between the doctors and the patients. And that was a big eye-opener for me, at least, was realizing that we were really communicating with their patients in a way that they weren't really understanding. There was just a disconnect, right? The other interesting thing was that as a result of that, we decided to make a video. And we made a video which was kind of a roundtable talking about this issue. And we decided to see whether or not that video was enough to stimulate the conversation for women. And currently we're getting some really interesting results that when women see a video that talks about these kinds of issues, it gets them to thinking, and it gets them to really realize that they want to have that conversation, that there are a lot of good reasons. Because when we looked at what women knew, what they understood about the process, you would say, I know, this is what got this whole thing started. They really didn't know enough. They really needed to know more. However, when we said to women, do you know enough to make a decision? Even if they knew very little, they would say, I know enough to decide that I want to get pregnant. And that was kind of scary for me. So I was glad to make a video where we were able to say, what do you need to know? How can we lay the foundation, put the seeds on the soil to get you thinking? And what we found is that women are now going to their providers and talking with their provider about, what do I need to know? What are my next steps? Where do I go from here?
And I want to just ask you a question, because you said that it scared you when they said that they want to get pregnant. You were scared because of the same things that scared me.
Mm-hmm.
If you want to have a baby and you're HIV positive, it's what I call safer conception.
Mm-hmm.
And that is the ideal time is when your viral load is suppressed, when you're on medications that are safe to be taking when you're pregnant, and most importantly, that you're not exposing yourself because you need to have unprotected sex to conceive, that you're not exposing yourself to a partner that may have a different kind of virus that you have, or if you have a negative partner, that you are doing everything that you can to help that partner stay negative. And we know the answers to a lot of those questions as providers. And so we want patients to dialogue with us so we can help plan for safer conception in the process. And I think those are the important questions to reverse. Are you using something to prevent pregnancy, but to have women plan their pregnancies, even if it's tomorrow or 6 months from now or a year from now, you can start planning today and get pregnant a long time from now. But if you have the tools in place, the toolkit to make sure that it's safer conception, that's what I think providers can offer clients, and we can offer clients the opportunity to practice this conversation.
Another thing, though, that's worth noting is that after we did this initial work, we got the idea to look at much younger women. And so we recruited women who were in their teens down to 18 years old, focusing on 18 to about 25. And we looked at that group among women who were perinatally infected, as well as women who were behaviorally infected. So two different groups, but the same kind of age. And what we found, which was really difficult, was that most of these women were depressed. They didn't know how to deal with life. They were really feeling very, very down, weren't telling their partners that they were positive, weren't using any kind of protection, and almost all wanted to have a child, wanted to conceive, and really weren't thinking, oh, I don't know. You know, their plans were very, very vague about how that would go, what would happen next. Sometimes weren't even concerned who the partner was going to be, as long as they got to have a baby. And I think that if we're going to acknowledge that it's a strong, I want to say a biological drive for women to have children, we have to acknowledge that is sometimes overpowering the best decisions we can make. And something that we need to prepare for, not try to prevent, but to prepare for. Looking down the road, how's that going to be, rather than saying, don't do that. And one of the things that we focused on was learning how to do motivational interviewing, so that we were able to work with the women where they were, instead of where we thought they should be, or where I thought they should be, or someone else thought they should be. Instead of being pejorative, don't do that, that's wrong, to say, meet with that person where they were and working with their decision making. How do they want to resolve that difficulty between, I want to have a child, I don't want to infect my partner, I want things the best, to work out the best. How do I make all of that happen?
Beautiful. Do you want to tell about the clinic you're planning for the fall?
Sure.
Yeah.
So after learning all of this, right? So can we go as far as say this is translational? But we learned so much from our patients. And what we discovered, we've got a large program here in Miami. We've got prenatal care program for HIV positive women. We've got GYN programs for HIV positive women, COLPO, HRA for HIV positive women. We've even got primary care for HIV positive women. But we need a clinic for preconception counseling. So starting in the fall, we're going to be opening a clinic where we can do just what we talked about, so that any provider who opens up the door, and there's a lot of providers that will ask the question, are you planning to have a pregnancy? But then may not want to go further because they may not have the skill set to really explore fertility, conception planning, all of those issues that go prep for the negative partner. So we're going to open a clinic so that people can refer to us, and we can sit, those of us that have the skills, and help them plan their pregnancy with their partner in the right way with the resources that they need. So,
Jonelle, one of the things I think is really important to include in that is the issue of disclosure. So many of the women that we see haven't disclosed their status, and they can't even get to first base in terms of working through that planning process if they can't disclose. And I think without addressing disclosure in that clinic, we're not going to really meet the whole need.
I know, and we learned a little bit about disclosure from the women we interviewed, and some of them told us that they wanted to disclose, but they wanted to have a baby so much more that they waited until they were pregnant and then they disclosed. And there's a disconnect there for me, because they were willing to take the risk of either becoming infected themselves or taking the chance that during the process of trying to conceive, having repeated multiple exposures with a negative partner, because the desire for pregnancy was so strong. And I think that we can work with ovulation, we can help them figure out when they're ovulating, and we can help the negative partners with PrEP and make it safe for everyone. So eliminating the stigma of disclosure and helping women disclose if it's safe for them, and working through that is a big part of what we need to address in that clinic. I agree.
Yeah. It's the same thing that we see in Africa, in terms of the work that I do there, that disclosure, that the stigma associated with HIV stops the disclosure, and the fear that women have of living with that stigma is real. It's real,
And I think it's not only for the women. For the HIV positive males that we interviewed that are HIV negative, they are really the group that is probably the most unrecognized. Everyone understands a lot about HIV positive women from all of the work that we've done, or the HIV negative women that are in couples with HIV positive partners. But then there's the group of HIV negative heterosexual men who live in a situation where there's a lot of stigma and they don't have anyone to talk to or get their information from.
Yeah.
So that's another target population that needs intervention, and we have interventions for them too. So we'll stay tuned.